I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
It's September, the summer's gone, but it's great to be recording another session. And the good news just keeps coming in myeloma in the UK, doesn't it, Sal? Big news this week?
Honestly, it's extraordinary actually, isn't it? I was thinking about this before we started recording today. It's almost like every month we're doing oh my goodness, there's a new development. But yeah, good news this week. A new drug regimen for older people who have just found out they've got myeloma. So fantastic. And that's what we're going to delve into today.
It felt very topical to talk about this at this moment. We did sort of just touch on this a little bit in one of our earlier pods when we were talking about the first treatment for patients who are not eligible for stem cell transplants. But now that this combination, well, one of the combinations that we can use now, a 4-drug combination.
So lots to delve into here. And I guess where we should probably start, Jam, I don't know what you think, is probably just talking about the clinical study itself and the sort of the advantages and the sort of disadvantages in so much that how much can we apply the learning from that study to actually the people we see day to day in clinic before we sort of deep dive into the drugs. I don't know if you've got any thoughts on that from how you understand it.
I think that will set the scene and help people understand how this combination came to be, and also whether it may be suitable for them as well, because it won't be suitable for everybody. Really, up till very recently, a 3-drug combination has been used more and really as a standard for people who are not eligible for stem cell transplantation. And there are some people that we still use a 2-drug combination for.
Generally, as a rule of thumb, when you're treating somebody living with myeloma, when their disease needs to be controlled, you need to get the balance right. And the balance involves making sure that the drugs you're giving work, but also that they're needed. And you're not giving treatments which someone isn't going to benefit from, or perhaps is going to give them undue side effects, lots of problems, which is going to make it hard for them to stay on treatment, and therefore perhaps even undoing the good work that's been done. And hence, some people might only have treatment which involves 2 drugs because the other ones aren't suitable or they can't tolerate it. Some may have 3 and some may have 4 with this newer regimen. And it's a case of getting that balance right. But I think as a rule of thumb, we generally say if you can give the 4 drugs, and of course the patient and their families are in agreement, that tends to translate into things going better for that patient.
So up till now in the UK, that 3-drug combination that we have been using as a standard is a combination of daratumumab, lenalidomide and dexamethasone. And we spoke about that at some length in a previous podcast. A smaller group of patients, we have just been using lenalidomide and dexamethasone. Now, another 3-drug combination that has been used for a number of years is the combination of bortezomib or Velcade with lenalidomide and dexamethasone, the so-called VRD regimen. Now, we've never used that in the United Kingdom because actually it's never had a license. But now, one of the 2 4-drug combinations that are coming, and we have the first one available now, is adding an antibody, an anti-CD38 antibody, onto the VRD combination. So Sally, this new combination we have available is VRD with Isatuximab, which is an anti-CD38 antibody.
So what we would refer to as Isa-VRD, but remember the V's and the R's might be, used to refer to other names of drugs. So the R is often lenalidomide and the V is often bortezomib as well. But what's so important about this combination of drugs is every single part of that regimen, the drugs work in different ways. So you've got your anti-CD38, which, as you said, is what we'd refer to as your ISA or your ISA, which is Isatuximab. Your V, which is your Velcade, which is a proteasome inhibitor. Your R, or your lenalidomide, which is an immunomodulatory drug. And then our old friend dexamethasone. But you're basically tackling the myeloma in 4 different ways. And that's why these combinations, these 4 drugs together, look like they work so well.
And for younger patients, so patients who are eligible for stem cell transplantation, this combination of using these 4 classes of drugs has been more standard for a longer period of time. But I think this combination and the other combination that is coming very soon, where instead of Isatuximab, use daratumumab, so that's DVRD, has shown that even in people who are not eligible for stem cell transplantation, there are many patients that will be able to gain significant benefit from what we call a quad or a quadruplet combination.
Totally. And I think there's one key reason I'm also very excited about being able to offer this to hopefully many of our patients we see in clinic is I always feel, Jam, and I'm sure you agree, that there's been a smaller group of people who I felt have been less well served, particularly when they're newly diagnosed with myeloma, because we haven't felt or we haven't been able to give the drug that we really want to give to improve how they're going to fare without significant compromise. And by that I mean Velcade or bortezomib. Now, Velcade really has a role when people present with kidney failure or when their kidneys are struggling. It calms down the myeloma and lets their kidneys heal. But up until this point, if you were older and you had kidney trouble, we tend to prefer a Velcade-containing regimen, but we'd also have wanted to give these anti-CD38 antibodies as well, but we haven't been able to give those two in combination. So it's great that this combination now allows us to do so.
You're right. So we've been a little bit hamstrung in some ways because this class of drugs that contains Velcade proteasome inhibitors are so important in rapidly controlling the disease and are very, very useful in renal failure. And when you have the 4-drug combination, it's built into the regimen already. And as you say, that allows you to get hopefully early rapid control and try and minimize further organ damage and then hopefully also, improve organ function, especially, the kidneys as we've just been talking about.
Great to have this regimen for that group of people. But also when you look at the data, I think what we've learned from understanding the study and NICE have now understood through funding this is actually with this 4-drug combination for people who are able to tolerate it and hopefully stay on it, their remission period is even longer. And that's now extending to many, many years, such that around the 5-year mark, 2/3 of people might still be in remission, the myeloma might still be under control. So I think that's quite sizable if you think about you're dealing with people who are a little bit older and hopefully alongside that, they're having a good quality of life as well.
I mean, that's a big number. And that is what the clinical trial showed. As we've said a number of times on this podcast, a clinical trial population is different to a real world population. But hopefully over the next 15 or 20 minutes or so, we can explain the trial, explain how the drugs are given, and then really get into how we think that this combination is going to be used in the real world. Because I think that is key, because there will be, I think, relatively significant differences in the way that the 4 drugs are implemented. And it will be really good to get into that. The trial was called the IMROS trial. So all trials have funny names, and this one clearly wanted to carry on with the funny names. I'm sure there's a good story behind it, but I don't know why it's called the IMROS trial. And I think an important point to make is that it looked at a sort of a defined population of patients who were not eligible for transplant, but there was an upper age limit, Sally, wasn't there?
There was, and the upper age limit was 18. Of course, many people in the real world are older than 80 when they're diagnosed with myeloma. So if you just take the study on its merits, well, what about those people? What do these combinations work so well in that group? Or is it as well tolerated? And I think that remains yet to be answered. But I also think it's worth us appreciating that it's not unusual for a clinical study to have an upper age limit, because it has to compare almost like with like, which tends to be trials and studies which have reported in the past, and they've also tended to have an upper age limit as well. So it can feel quite restrictive at times when you try and then look at the data and you say, well, this is really good. Yeah, but what about everyone else? But I do think there is some thought that's gone into that. And it's not just wanting to be biased against older people. It's also because to prove that the treatment works, you have to set your limits somewhere. But yeah, 80 is the cutoff. But I'm sure we've both experienced many people in clinical practice who might be 80, but might be pretty good at 80, really getting on with their lives with a really great quality of life. Given how well this combination works, it should be up for discussion with that group of patients as well.
Yeah, and I think a point to be made is that plenty of trials don't have an upper age limit, but the number of patients over 80 in the trial is always very small. I think very correctly, the combination, there is no upper age limit that it can be used at in clinical practice, and that is, determined by the clinician and the MDT making that decision, which is, absolutely correct. The 4 drugs, so the anti-CD38 antibody, Isatuximab. So this is different to daratumumab, right, Sally? So it's not daratumumab, which we've talked about a lot, is given as a small injection under a skin, but this drug is given intravenously.
It is, yeah. It's an IV infusion, which I think, some people might think, oh, goodness, I've got to have a cannula every time. That's a bit of a fiddle. And yeah, granted, it is a bit of a fiddle. But I would suggest that if that opens the door to this regimen, it's certainly worth considering. And the infusion, there is always this risk, even actually with the daratumumab treatments, when you first have it, you might react to it. So first time round when you're exposed to this class of drug, if you've never had it before, it will take longer to give and you'll be monitored more closely. But once you're established on it, and by that I mean actually, literally, second time onwards, you can give it much more quickly. Now, if you read what we call the SPC, which is the medical or pharmacy way of describing how the drug works and should be given, it should be given over 75 minutes. But we've been using this drug in other settings, so in clinical studies, for example, and we have actually been able to give it more quickly than that. So it may very much depend on where the person's being treated. I'm sure the clinical teams at that site will be considering, well, is there any way we can change this infusion time so it's not quite so inconvenient for everybody?
And initially it's given weekly, and then over time it changes to every other week, so fortnightly, and eventually after I think about a year and a half, it drops down to once a month. The lenalidomide, which a number of our listeners will be very familiar with, is given for 14 days initially, and then you have a week off, and then it's given for another 14 days. So it's a slightly sort of unusual from that perspective, because historically lenalidomide has more often been given sort of 3 weekly and then a week off. And then Velcade, the subcutaneous injection, the bortezomib, in the trial at least, it was given twice a week initially for the first 2 weeks, and then you have a week off, and then it's given again for another 2 weeks.
Even as you describe this, and I'm quite familiar with this study, I think it's fair to say, I'm listening to you and thinking, oh, okay, so this is happening on this day and that's happening on that day. And then, so what am I going to have to do this week and the next week? And I think particularly for the doctors and the nurses who will be, helping and prescribing this treatment, it could be a little bit of a muddle for us. So I suspect there might be a little bit of change to these regimens so they better suit the patients, and also so that we're not sort of at risk of exposing patients to lots of side effects. We very infrequently give Velcade twice a week, for example. It tends to be every week, doesn't it? And as you said, lenalidomide we tend to give for 3 weeks out of 4. So I wonder if local practices, again, might differ a little bit and just deviate away from the clinical study, not to minimise how well the treatment works, but actually to hopefully keep people on treatment for longer so they get fewer side effects.
I think it's important to say that the Velcade essentially continues for a total of 24 weeks. So it's, they call them 6-week cycles, but it's 24 weeks. And then it goes down from 4 drugs to 3 drugs, right? So we talk about this as a 4-drug combination, which absolutely it is. But then the Velcade, has had its effect. And we know after sort of decades of using Velcade that giving it for any longer, you tend to run into more side effects than benefit, especially neuropathy. So I think very appropriately, it drops down to 3 drugs. But like all these combinations, I think people end up reducing the steroids quicker. And again, the lenalidomide is a drug where it's easy to sort of, modulate the dose as well.
Definitely. So this is about the sort of clinical utility and what happens in the real world, and that will evolve with time. And again, we've spoken to that on previous podcasts. I think in our trials podcast, we spoke particularly about Velcade actually, and how we used to give it twice a week, and that was what was done in the studies. And then we learnt to give it differently, and people cope just as well, and it works, just as well, but with fewer problems. So I think the same will happen here. Something which I suspect for our listeners and particularly their family and friends might want to know about this drug combination. Can you talk me through if giving 4 drugs together does mean that you have to be more cautious in terms of side effects? What's the downside of this combination?
You do have to be cautious, absolutely. And we know that we have to think about the side effects of all of the drugs individually. I mentioned neuropathy with Velcade. The common side effects of lenalidomide, just to refresh everyone's memories, the increased risk of blood clots, cramps, rash, diarrhea. And then when you add the steroids, of course, you have the full combination of all the steroid side effects of our deadly dex, as we call it. And then Isatuximab, this anti-CD38 antibody, reduces the immune system. But I think when you take all of them together, I think the thing that we, particularly worry about when we're using a 4-drug combination is the risk of infection, sort of significant infection, and that's often driven by both a combination of reduction in blood counts, but also effects on the immune system. And Sally, I think we should focus now and talk a little bit about the risk of infection and what was seen when this drug was developed.
Just as a caveat into that, for people who are living with myeloma, I think we must also remember that having myeloma itself, particularly if it hasn't been controlled, does increase your vulnerability to infection. And the other second really important point is it takes time for these studies to what we call mature, which means you've got to watch people for a while when they start the treatment to see what happens. And so therefore, when you get your final answer, for example, up to 2/3 of people might still be in remission at 5 years, you're looking back in time. They started treatment 2018, 2019, 2020. And of course, let's not forget that's when we were in the middle of a pandemic. So when you actually look at this data, there's certainly a signal in terms of chest infections and pneumonia, and that's real. And I strongly suspect that that's something we'll have to pay a great deal of attention to. But also COVID-19 occurred for patients on this study, unfortunately. But generally, if you look at how long people on treatment, actually adding in the Isatuximab drug didn't tend to make a significant difference over all that time to serious infections. Chest infections, yes, but serious, nasty, staying in hospital for weeks and weeks at a time, it looks like it was much of a muchness.
In terms of minimising the risk of those sorts of infectious side effects, Sally, is it just standard sort of antibiotic, what we call prophylaxis, that people would use? Is there anything special that we do for this combination that we wouldn't normally do for other first-line treatments?
I don't think it's anything particularly special. It's always worth reminding our listeners the importance of vaccinations, particularly if you can get those vaccinations in before you start your treatment, that's invaluable. But also they did see a reduction of infections for people who were taking more regular antibiotics, for example, cotrimoxazole, which is what we tend to prescribe routinely in clinical practice as well. So I suspect there will be some antibiotics and antivirals, cotrimoxazole or acyclovir, given as part of this regimen. And I would encourage patients, where possible, to stay on those antibiotics. So take the tablets that you're given, and if you can, try and get vaccinated before you start. But if not, do get your vaccinations as you go along. And then my last really important point is, of course, if you do pick something up, don't just wait and think, well, I'm seeing the doctor at the end of the week, I'll deal with it then. Get help. And, it's always better to seek attention so that if something is brewing, we can get on top of it early.
I would say that about half the patients do appear to get diarrhea on this combination. Half get neuropathy as well, approximately. And lots of people get what we call neutropenia, one of the white cells that are important in fighting infection, with 50% getting quite significant neutropenia. We have good medications to minimize that. This GCSF injection can keep people's blood counts up, and I do think lots of people will need GCSF potentially with this combination. What is reassuring, side effects like diarrhea and neuropathy, I think myeloma doctors, we're used to looking after them. I think what will happen, and we alluded to this at the start of the podcast, is that the doses that people get will drop quite quickly to really sort of minimize the impact of some of these side effects.
Definitely. We'll modify them as we go along, as we do already with all the other regimens. This will be no different from what we do otherwise. Stopping the steroids when someone's in a nice remission, weekly Velcade, lowering the lenalidomide, and so on and so forth. Whatever it takes to keep that person well but on treatment. So if that does happen to any of our listeners here, please don't be alarmed by it. It doesn't mean you're doing anything wrong. Actually, it might mean the treatment's working really well. You simply don't need all those drugs. Ask those questions of your treating team, but know that that's quite normal, actually. It'd be very, very unusual outside of a clinical study for somebody to stay on exactly the same dose after a year that they were prescribed at the very beginning.
That's a really nice point. We would expect quite a lot of personalisation, and your doctor will look at your myeloma. What is the genetic risk of your myeloma? How have you responded to the treatment? And what your side effects are, and what your preferences are. And then really all of those four things you put into the decision matrix and hopefully end up on the right combination of drugs. Because there may be some people, for example, who we think would really benefit from staying on the 4 drugs for as long as possible, because we think they have genetically high risk disease, say the kidneys are very bad to start with, and it just makes more sense. But other people who have maybe more stable disease, and this is a group of patients who would do and are doing well on our standard 3 drug combination at the moment, daratumumab, lenalidomide and dexamethasone, and it may be that 3 drugs for them will work very well still for a number of years. So I think there will be a lot of bespoke treatment, as it should be.
Definitely, because we're dealing with people, aren't we, and individuals, and everyone wants to, we've spoken about this a lot, don't we, go on holiday, carry on with their lives, not be too worried about side effects and toxicity. So it's understanding that about the person that's in front of you. But isn't it brilliant? Honestly, isn't it fantastic? Because there are going to be some people in a decade's time that are still on this treatment, it's modified, and they're still in remission. For some people, maybe it's talking about the myeloma being under control for a significant period of time. And I find that really, really, really heartening, and I hope our listeners do as well.
For people who are older, this combination of drugs may be the only combination of drugs they have for their myeloma. If you're diagnosed at the age of 76, 77, and you're controlling your myeloma for that length of time, the myeloma is not going to be life-limiting, potentially. We know that 92% of people will respond to this combination of drugs. I mean, it's such a high number to hear, but it's very, very high. The trial was very good at looking and monitoring for completely undetectable disease, what we call, MRD negativity. So you can't detect the myeloma at all. The rates of what we call MRD negativity, were extremely high, with about 50% of patients MRD negativity sustained. So, it was measured at 2 time points, and that in about half of patients, undetectable. Really very good results.
Yeah, and we know that MRD piece, and we'll probably do a separate pod on this, I suspect, Jan, won't we? Because it's quite confusing what it means, and what hopefully your team may be explaining in the future when we can actually test for it routinely. So that's why we need to do a separate podcast on it. But this testing is largely done in clinical studies. It's not done in the real world. But when it's done in a clinical study, what those 2 negative time points tend to translate to is just the disease staying away for even longer, which is why it's so important. But yeah, watch this space in terms of MRD in the future for every day-to-day patient. So hopefully we'll be doing a podcast on that in the future.
Yeah, and just to then reiterate, Sally, so about 5 years, about 2/3 of patients are still in remission, essentially.
Yeah.
Yeah.
Yeah. On one hand, I guess when I talk to you, Jam, or talk to other specialists in this field, I get so delighted about the progress, but we do also have to hold in our minds that there's still some people who unfortunately don't fall into that group, and they still do remain a challenge. But again, that's all about understanding the myeloma, having those conversations with the team around you to really figure out what the right treatment is. Because let's not forget, for those patients who fall on the wrong side of that remission curve, there are still other options available, which hopefully where they will have a response to and will hold their myeloma for some time.
Sally, I'm going to ask you some difficult questions now. This changes the scene, right? When we are in our MDTs now and discussing options, we all have patients that we see every week who we like the idea that of them being strong enough and fit enough for a stem cell transplant, but we're not sure. But we think on balance, going down what historically has been the more intensive pathway, as we call it, is the right thing for them. So for those patients now, should the way people think about things change? Or if we think they are borderline for transplant, but we still think it's the best thing for them, should we push on with what we call the transplant quad, which in the UK, sorry for the acronyms, guys, honestly, it's endless, DVTD and a transplant? Or would it be better for them to have this combination because actually they're borderline ineligible?
Okay, right, let's dive into this. Well, I'll try and keep it simple. I think we could debate this endlessly, as could so many of our colleagues.
And we will, I'm sure.
Yeah.
I might literally start next week at the MDT, where we're going to be having these discussions
my God, so hard.
From now. And that's the thing, right? You get a new treatment combination and there's no sort of lead-in time, right? You're having that discussion literally next week.
Straight away,
Yeah,
straight away. But without being too cheesy, but this is from the heart. Clearly, the most important person in this conversation is a patient and their family and their friends. And that's kind of on us and the clinical teams to really talk through the pros and cons.
Give me the best treatment, doctor. I trust you. I will do whatever you think is right.
Yeah. Well, then I would have to take into account what I understand about, as you've said, the genetic risk of their disease, which is subject to another podcast in the future, and what their preferred approach would be in terms of intensity of treatment and also potential side effects of treatment. It's really, really worth saying, however, that our current regimen for the transplant pathway, this DVTD combination, transplant, a bit more of these 4 drugs, and then Len maintenance, well, there hasn't been one trial grouping all of those drugs together. So we're learning about how long they work for as we go along. And it may be that we find that you're dealing with a remission period of roughly the same time. I can't say for sure that, on average, people respond for this long if they have a transplant, given our current drugs. And in the other study, they respond for this long because we just simply don't have that data. But one of the benefits, I would say, of this regimen is the fact long-term you get your lenalidomide and you get your Isatuximab. And those 2 types of drugs look like they do a really good job at controlling the myeloma.
This is the problem. And these are the discussions that people will be having. And in myeloma, we have to spend a lot of time sometimes just comparing across trials, which is not a sensible thing to do, but everyone does it endlessly. Or you're comparing things where actually you're doing something that actually there's no long-term data for. But the great thing is that we have options, and it's about discussing the options and explaining what we can do. And we shouldn't forget, a transplant is not an insignificant undertaking. And I do think that people who are borderline for transplant will preferably be getting this combination. And I think that's going to be the right thing to do, because there is nothing worse than someone dying during a transplant cell, and we've all seen it. And it's not like that this combination is without risk. There were deaths on the trial in this combination, and there were more deaths than were seen with VRD, which was the comparator. And I think it's very important to mention that. The thing about continuous treatment is that you can look at side effects in lots of ways, and you can say, yes, you divide it over the number of years that someone's on treatment, but the point is that the bad event still happens. And this is an inherent weakness with some treatments at the moment, is that they're continuous. And if we're still doing the pod in 5 years, Sally, or 7 years, hopefully we'll be having lots of discussions about time restricted treatment, people not having the side effect because they're not on treatment. But I think at sort of the lower end of the, if you think of this combination of drugs, you've got the lower end, which we've just talked about, people who are potentially eligible for a stem cell transplant, but you're really not quite sure. I think lots of those people will go on VRD. And to be honest, a lot of those people now are going on DRD, right? To be fair. So it's already happening, and it will be an extension of that. But what about at the top end then, Sally? People who are older, are frailer. We've all seen people, unfortunately, that we worry about giving 2 drugs to. So the thought of giving 4 drugs is going to be impossible. There is a clear population of people who will never be really eligible for a 4-drug combination.
And of course, you've got to think about practicalities, haven't you? I mean, this is pretty intense, the infusion, every week for 5 weeks and every fortnight. Seems like it goes on for months. Well, it does go on for months. And then there's those practical aspects. Can someone get into hospital? Is that easy for them? Is this manageable? Can it be given closer to home? And that might in itself might be a reason to choose a different path, because it's about quality of life, isn't it, really, and how you're choosing to spend your time. But it's also worth saying that there is some early data coming out looking at frailer people who aren't super fit, but they're good enough to come up to hospital once a week, and they're keen to be considered for this. And it looks like they also benefit from this 4-drug regimen. But if that is the case, when I see people in clinic and discuss this, I'll be saying to them, well, perhaps we'll go in at a lower dose, and perhaps we'll see how you get on with it, and we can always change tack if things don't work out. And I think that's the approach many of us will be adopting.
What that potentially speaks to is that some of that frailty is driven by the myeloma, and by using effective drugs that work quickly, potentially you can alleviate some of that frailty.
Definitely. Let's not forget that, some people, really do take a terrible hit, when they're diagnosed with myeloma because their kidneys aren't working, because their bones are struggling. But you can often, I hope, with most people, get them back to how they remember they were. And therefore, a treatment like this could be completely the right path for them. So very bespoke, very much in the hands of the clinical teams. And I really hope for our listeners today that this podcast provided an overview of how to sort of consider these things. And also, really importantly, Jam, I guess it's quite handy to know what's going through our minds as well, particularly if you're a patient or a relative, because we're weighing these things up, but we often don't have times to express it, do we, in clinic? And it's just so overwhelming in such a model. So yeah, reach out, guys, if you want to explore some of the nuances of this topic a little bit more.
So the current standard treatment that we're using a lot of at the moment, Sally, daratumumab, lenalidomide and dexamethasone. My view is that there is still going to be a relatively big role for this combination of three drugs. We understand it extremely well, and I think it's absolutely superb treatment for people who have genetically stable myeloma. We've talked about, of course, the benefits of Velcade in lots of situations and the benefits of a quadruplet, 4-drug combination. But there are some people that do amazingly well with what we call this DRD combination. And we know with them, on average, 50% will be in remission at 5 years. It's significantly less toxic. Neuropathy should not be forgotten. Certainly we don't forget it. But, to live with even sort of lowish grade neuropathy for the rest of your life is not a nice thing and can have a big impact on quality of life. I'm totally with you. I think, the 4-drug combinations are here and we're going to be using them from next week. And I think the daratumumab VRD will be coming in soon. I'm a big fan of DRD in certain and, a reasonable number of situations. It will continue to be good treatment. Not everyone will have that view. And I think that's why it's good to discuss these things.
Again, when you look at the studies and when you look at So DRD, the Maya study, compared the 3 drugs to 2 drugs. And what was interesting about that study, I think, is that for people who had 3 drugs, albeit in the study, they had a significant uplift in their quality of life. So it looks like, if you believe the study, that they felt better than the people who only had 2 drugs, suggesting that more is actually more. And that might be because their disease is better controlled for longer or whatever. Not quite sure if that translates into the real world in the same way, because you have to come up for the daratumumab for a start, which is an inconvenience, and such like. So who knows? That remains an unanswered question. But equally, with this 4-drug regimen in the study, it didn't look like people who had it, as opposed to 3 drugs, felt worse. They got more side effects over time, but their quality of life looked about much the same. It's figuring out the right approach for the right patient in terms of, what are their choices? Some people come with nasty neurological toxicities, and so you don't want to give them Velcade because that can make it a whole lot worse. Or some people, you might really struggle to get cannulas in, and that's going to be an absolute shocker. So you're not going to give them Isatuximab every week. So, it's making it more bespoke. I think that's a really important thing to say.
But it's great to have options.
Isn't it? What a gift. What a gift. And I just hope that we can communicate in a way which is clear and meaningful for everyone to make sure that people make the right choice. And sometimes you can change your mind, but often, particularly in the NHS, unfortunately, when you commit to a path, you sort of have to see it through. So we can drop drugs, but it's quite hard to add different ones in. So that's always worth remembering as well. I think consider it carefully, get as much information as possible, perhaps even try and reach out to other patients who've been on this regimen and see what they think as well. And let's not forget the specialist nurses as well, because they can give a really nice, honest opinion as to how they see things too. So Jam, it's been a really interesting discussion. Honestly, every time I talk about this subject, anything to do with myeloma, particularly with you, I must say, I always learn a lot more.
Thank you for that. The point I was waiting for us. There you go. It's myeloma and me. What a heady combination.
Indeed. Always a pleasure.
What else do you need?
Just to sum up really for our listeners. So just know that this combination is out there, and it could be of significant benefit for a proportion of people who are older and perhaps aren't fit for a transplant or don't want to consider a transplant, and shows some great promise in terms of how well the drugs work together and how long they work for. So bear it in mind. guidelines. It's coming to you very soon. And like I said, please reach out to us if there are any questions.
Brilliant. Thank you, Sally. It is the start of a new era of 4-drug combinations for our older patients, but I think it's a really exciting time, and we look forward to discussing more topics with you over the coming weeks. So thanks all for listening, and we'll see you at the next one.
Cheers.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.